behaving as they once did. However, we have to be very cautious when children are untreated that they're not self-medicating. Same is true of adults. Comorbid conditions, again, as we note here, particularly anxiety and depression, can appear as if they're ADHD when in fact it may not be, and/or can be concurrent, comorbid with attention deficit hyperactivity disorder, because we see these running together quite a bit. Again, the diagnostic criteria, you all can see this. I don't want to wear you out with it. We know these individuals fail to focus on details. We know they have difficulty sustaining attention. They do not seem to listen when spoken to or addressed. We notice that they don't follow through with instructions and directions. They fail to finish schoolwork, chores. In fact, they may even do their homework. They fail to hand it in. They do their homework, they take it to school, it's in their backpack. They forget to hand it in. They bring it home, and now they're failing the course, even though they're doing the homework. So we need to, oftentimes as clinicians, make arrangements at the school for homework to be collected there, put in an envelope by parents at night, and all of it handed in at a central location and then distributed to the appropriate classes. These individuals also have difficulty organizing. We see this in adults as well. They do not like to engage in activities that require a lot of mental energy. They lose things, as we mentioned earlier. They're easily distracted by extraneous stimuli, and they can be very forgetful in daily activities. It sounds like a lot of us here in the room. However, it's when it becomes totally disruptive of their academic activities that we truly need to intervene. Hyperactivity, we see the hyperactivity, and what we see is the fidgeting. We see these youngsters who won't stay in their seat. We see them climb, they run about, they have difficulty playing quietly and entertaining themselves. They're on the go. The key phrase, and I hear this from mothers and fathers regularly, it is as if my child is driven by a motor. They talk excessively. They may even talk rapidly. We see this. Again, it's important to keep in mind, in a family that has a family history of obsessive compulsive disorder, we need to rule that out as well, because the youngster who gets up out of his chair, runs out in the hallway, hops on his left foot 3 times, pirouettes 3 times, comes back into the classroom, slapping the door jamb 3 times, sits at his desk, drumming out triplets, may in fact have an anxiety-driven ritual perspective of OCD, obsessive compulsive disorder, that is misperceived as ADHD, and the treatment approaches are totally different. We need to keep these types of things in mind. A good family history is critical. Hyperactivity, impulsivity, these are the youngsters, they blurt out answers. These are the youngsters who would probably do well on Jeopardy. They have difficulty awaiting turns. They interrupt and intrude on others. What are the causes? We don't know. We believe there's a genetic predisposition. Typically and traditionally, when we have an ADHD youngster, again, as mentioned earlier, one or both of the parents have attention deficit hyperactivity disorder. We believe that family history is critical. We must obtain a good family history. All too often, when I am evaluating a youngster, after I've completed the evaluation, one or both of the parents will say to me on the side after we're done, you know, I was just like this as a child, and I think I still am. And typically and traditionally, when I prescribe medication for the child, the parents will call me. They've run out of the medication 2 or 3 days early. You already know why. The parent has sampled the medication, him or herself. And the next question the parent asks me, can you prescribe that for me? So again, we see a strong family history. We know rare causes, prenatal cocaine, alcohol, tobacco. This is when the child is receiving free womb and board and is bathed in these illicit substances, adversely impacting the central nervous system. We see a slightly different type of ADHD. And again, for these youngsters with this desensitized, activated central nervous system, when they're in utero, we can see difficulties with them in focusing, concentrating, and sitting quietly. We have to rule out traumatic brain injury. We see that a lot. Individuals with head injuries, traumatic brain injuries, have difficulty focusing, concentrating, staying on task and on track. Lead or other toxins, yes, we still see this. In my practice, I have patients who present. We still have to test for that because many of our youngsters are still at risk for being exposed to lead in some form or another. And I see that in practice. Prematurity. We've noticed that the premature youngsters that we do see a greater proportion of ADHD-like symptoms. Now it says at the bottom it's not caused by sugar, food additives, allergies, immunizations. Well, studies say that this is not the cause. Parents will take issue with that. And so when I have parents who say to me, Dr. G, I find when my child drinks 2 or 3 Mountain Dews, has too much chocolate, gets too much of a given food additive or a dye, that my child acts totally, quote unquote, off the wall. My advice to them is, then take that out of their diet. It certainly won't hurt a youngster to have less soda pop. It won't hurt the youngster to have less sugar-containing foods and to be on a healthier diet. It impacts all aspects of the patient's life. You see, what happens, we see it adversely impact school work. It can affect bedtime for these youngsters. Many youngsters, because of their ADHD, can't organize well enough to get to bed at a decent time. Their sleep habits get disrupted. When these youngsters don't sleep well, what happens? Then they don't focus well during the day. Then their mood is decreased. Then what we see is these youngsters can't get up in the morning to go to school. And it sets up this downward spiral. Driving, this is critical for adolescents. It is so important for adolescents with attention deficit hyperactivity disorder that we're aware that when we place them on medication, they need to have the medication in place and being effective at times critical to safety. That means on a Friday night if they're going out on a date. Unless we as a parent or a practicing attorney who wants to handle our child's traffic citations and violations at no cost, then we can hold off on the medication. Otherwise, it's critical. We want them focused and concentrating so they stop at the stop sign, so they look left and right before they turn. And unless we want to become a grandparent too soon because of their impulsivity and intrusivity, when they're going out on a date, we want to be sure they've had their medication. It affects sports as well. The youngster who has attention deficit hyperactivity disorder, the boy or girl who's playing in sports, if they haven't had their medication and they need it, they're off daydreaming when a line fly comes to them and instead of landing in their glove, it hits them on the head. Now we have the traumatic brain injury. Now we have a confounder. Is this ADHD or is this due to the traumatic brain injury? So again, it affects every aspect of the child and adolescent's life, as well as the parent's life. Again, this shows the comorbid conditions, and this comes out of the MTA study and the National Comorbidity Study. You'll notice we see the ADHD and anxiety, conduct disorder, tic disorders, mood disorders, and that's in children and adolescents. In the adults, again, we see anxiety disorders, mood disorders, intermittent explosive disorder, and substance use disorder. All too often what happens in adults, they're treated as a child or an adolescent with ADHD, and then they've been taught the myth that you outgrow ADHD, and so they stop their medications once they become 18. The reality is 30 to 60% still have ADHD, so now they're seeking to self-medicate for whatever they perceive their problems to be, and that's where they get into trouble with substance use and abuse. Question. Parents have identified impairment from a child's symptoms. What is the next step we're going to take? Please take a peek and vote. Okay, review the rating scales from parents and teachers in report cards. Screen for medical neurologic problems, lead levels, CT scan, TSH, EEG. Discuss pharmacologic and non-pharmacologic treatment for ADHD, and order a neuropsych workup to assess for IQ and learning disabilities. Actually, we do all of these. However, which one do we do first? First thing we're going to do is review the rating scales from the parents and the teachers in the report card, because that gives us the greatest amount of information up front on what's happening in the different venues of the child's performance. We do a history and physical exam. History and physical is critical again, because we want to rule out any and all of the above. Chronic illnesses are going to impact a child's ability to focus, concentrate. Visual auditory problems, we need to realize if the child can't see the board or the child can't hear the teacher, he or she is not going to be responsive and is not going to be successful in his or her academic performance. Seizure disorders, of course, we need to rule those out. Sleep disorders, we're seeing more and more sleep apnea-hypopnea syndrome in the younger populations. We need to rule that out as well. Severe anxiety, depression, and abuse. If a child is being physically, sexually, or emotionally abused, he or she is not going to perform well at school or anywhere else in their life. We need to rule out cardiac problems. The reason we rule that out by a good family history is because when we initiate medication, we want to be certain with a psychostimulant that we're not putting the child at risk for a cardiac issue. Again, the current studies say it's safe, and the safety for utilizing a psychostimulant is there for us unless there's a strong family history of cardiac issues that we have to monitor then, and or if the child has had prior issues with regard to cardiac compromise. Initial tests that we don't need to do. We don't need to get the CBC, lead level, iron level, thyroid stimulating hormone. We don't need to do an EEG. We don't need to get a CT or an MRI of the head. We don't need to do the sleep studies. We just get a good history. We don't do the continuous performance tests or an EKG, ECG, unless we have an indication. The best tests we have are the clinical evaluation and the family history, as well as the performance tests that we receive from the school. Should we perform an ECG? As you can see from these studies, I'm not going to wear you out with it. It has been stated based on the AAP and the AACAP, which is the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry. With all the research and studies that have been done, it has been concluded we really don't need to do the upfront studies. If you feel more comfortable obtaining an ECG or an EKG and the insurance company is willing to pay for it, by all means, feel comfortable doing it. When we used to utilize imipramine, a tricyclic antidepressant, as our key ADHD treatment approach because it gave us more bang for our buck, it would calm anxiety, it would improve mood, it would facilitate sleep, it would help treat nocturnal enuresis, as well as helping with focus and concentration because of its tricyclic benefit. We would obtain an ECG because of its potential to slow electrical conduction through the heart, as well as cause a reflex tachycardia. However, now, with the meds that we're using, we don't feel it's necessary to obtain that as a matter of course. What do we do for the pre-visit requirements before the child presents to our office? We want to obtain the checklist from the school and from the parents. We'll look at copies of a report card. We can check achievement scores after third grade, so fourth grade on. If an IQ test is available, if there is neuropsych testing available to us, it's prudent to access that information before the child comes so we know what we're dealing with, because then we know whether or not we need to start thinking about referrals of this child for other types of interventions. And we want to talk to any primary caregivers if we can, and for so long as we have permission to do so. If grandma or grandpa, aunt or uncle, someone else is the primary caregiver, we want to get information from them as well. The workup, We have different checklists, and you can see they're here. They're all valuable. They're all good. What we tend to use most and what we utilize most is the Conners. The ones with the asterisks are available online. Feel free to download those and use those. And how good are these screens? Well, you'll see here listed specificity and sensitivity. The Conners seems to be the scale that we use the most, and it seems to provide the greatest gold in getting the results. When it comes to following guidelines, guidelines are big right now. We're talking about guidelines, evidence-based medicine. We see it in our own journals. When we talk about this, we know that of those primary care providers who were interviewed, asked through survey whether or not they rely on these guidelines, 824 in this study of the survey were returned, and we noticed that while 91.5% of pediatricians were aware of the guidelines, the number who actually use the guidelines, as you will see, is small. Most of us make a diagnosis clinically. Most of us then intervene and treat based on our clinical experience, based on what we hear in conferences, what we read in the journals, and what we know from our own empirical experience. Recent studies on ADHD have reported that the best therapy is, here we go, we'll vote, the best therapy when one intervenes to treat for attention deficit hyperactivity disorder. Combination methylphenidate behavior therapy. And I want you to know that while I as a clinician agree with you, and while I as a clinician intervene and do that, I do both therapy, family therapy, individual therapy for the patient with ADHD, and intervene with the medication. Believe it or not, the studies have stated that methylphenidate alone is the therapy of choice. My belief is, and I agree, my belief is what they're saying is if you can only do one thing, then intervene with the psychostimulant. Preferably, we do both. Preferably, we have to intervene with parents. Because medication, while yes, it may help the child focus and concentrate, and since this is something new for the child, now we need to intervene. Teach parents how to deal with the child who is now able to focus and concentrate. Teach the parents not to constantly say to the child, did you take your medication? Did you take your medication? We need to teach the parents now how to set consistent boundaries, how to say no, and so it is important. We also need to let parents know that if they don't give the medication on a given day, then they can expect the same kind of behaviors they used to have before the medication was given initially. And once they start to get the consistent boundaries in place, they may start to see a change. So again, I believe that we do the combination. However, the studies have shown if you can do only one thing, it's get the medication on board. Which treatment is best? Now again, when we look at this, methylphenidate has been shown to be one of the most effective treatments. You all may know it under certain brand names of Ritalin, Focalin, Metadate, Concerta. These are the methylphenidate medications. Methylphenidate is effective in a certain percentage of children and adolescents as well as adults. There is then also a percentage of children, adolescents, and adults who may respond better to the amphetamine dextroamphetamine mixed salt that you may know under the branded names of Adderall and Vyvanse. And then, of course, we know that some of the youngsters are going to do better on a non-stimulant medication. The reason being they may have underlying issues such as tic disorders, they may have a transient tic disorder or an actual full-time tic disorder or a Tourette's disorder, and so they may be better candidates for a non-psychostimulant. We're going to look at those as well. Again, treatment that is best for preschoolers. Yikes! We say here behavior therapy remains the recommended first-line approach. The reason for that is this. Preschoolers are under the age of 6. Are any of the medications FDA approved for children under the age of 6? This is the dilemma. In fact, one medication is FDA approved from ages 3 up. That is the amphetamine dexamphetamine, yet most clinicians are quite hesitant to initiate a youngster under the age of 6 on an amphetamine dexamphetamine. Plus, those of you who treat patients through insurance as their primary financial support, whether it be Medicaid or some other insurance, many of those insurance companies are very loath to approve psychostimulant under the age of 6. Even though the amphetamine dexamphetamine, Adderall, is FDA approved, 3 to 6, most Medicaid and insurance companies will make you jump through so many hoops that the child will have turned 6 by the time they authorize the prior authorization approval. Treatment of ADHD. Notice here, 81.3% of individuals with ADHD are prescribed medication. 53.4% are prescribed behavioral therapy. 53.1% were seen 3 or 4 times a year. And many no accessible mental health resources, and many have insurance limits. Again, one of the keys, if you're going to start a child on a psychostimulant, please see the child back in your office at least 3 to 4 times a year. You want to observe, you want to be certain that the child is not having any adverse events. You also want to be sure that the dose that you're using is effective, because in order for a psychostimulant to be effective, you have to hit the therapeutic threshold. What is a therapeutic trial? The right amount for the right amount of time. Too much of a dose given for too short a period of time will not give us an appropriate result, and too low a dose given for too long a time will just be running in place. So we want to see the child back often enough. We want the parents to be able to call us and give us information. Again, this is the list of FDA-approved medications. As you look at this list, you'll notice amphetamine says 3 and older, and dextroamphetamine is 3 and older. That is, in fact, your Adderall. Effects of stimulants. 70% of individuals respond to your first choice, 90% by the second or third choice. Those of you who are most comfortable in utilizing one type of stimulant over another, that's fine. If your comfort level is with methylphenidate, start your patients there. If your comfort level is with the amphetamine dextroamphetamines, start your patients there. And then observe. If they do well, great. If they don't, then switch to the other psychostimulant, because some youngsters will do better on methylphenidate, some will do better on amphetamine dextroamphetamine. We just don't know. And so, again, bless you, so much of this is trial and error. Drug holidays. Drug holidays. That doesn't mean that you provide someone with an illicit substance and send them off on a vacation. Drug holidays mean that the patient is without the substance, the medication, for a certain amount of time. It is okay to say to parents, if you don't want your child on the medication on Saturday and Sunday, that's okay. Typically and traditionally, after a child is placed on the medication and done so successfully, after one weekend off the medication, the parents won't do that again. It is okay from time to time to recommend in the summer, when the child is out of school and maybe has a couple of days, to hold the medication to see if the child has reached that point where the wiring to the frontal lobes is now intact and the youngster may no longer have need for medication to treat the ADHD. Again, remember, we say that 30 to 60% of children and adolescents with ADHD will persist into adulthood with ADHD. That also means that 30 to 60% won't. So with that being the case, we need to check periodically. We do know that ADHD is a 7-day-a-week, 365-day-a-year condition. We also know that it's 24 hours a day. It doesn't just go away because school's out, and it doesn't just go away because the weekend's in place. We also know we have to be very, very cautious and careful. Interestingly enough, and paradoxically, ironically as it were, treating children at school where there is the most structure and the greatest amount of faculty and staff to catch the child if he or she doesn't have the medication, that's where we always have the child on the medication. On the weekends that are totally unstructured and typically in chaotic homes, that's where parents say it's okay to hold the medication. Ironically, they probably need it for sure at home. At least the school has structure in place if they miss a dose. So again, we want to explain that to parents. Children unsupervised are at greatest risk because of their impulsive, intrusive, risk-taking behaviors for injuries if they don't get their medication. As we noted, chronic condition, we need to monitor for home care and other special needs if indicated. Preschool-aged children, again, we talked about intervening with behavior therapy first. Typically, we do that because we want to be certain that the parents are learning to set consistent, firm boundaries for the children before we intervene with medication. The medication essentially is psychiatric aspirin. What the medications do in psychiatry, calm the acuity of the psychiatric diagnosis. Once we calm the acuity, now we can intervene with boundaries, with therapy, and with other types of non-pharmacologic interventions. Again, this talks about intervening first with parent training and then taking it from there. This was the study by Lawrence Greenhill, Larry Greenhill, and others, showing that preschoolers, we want to intervene first without medication. However, typically and traditionally in my practice as a child and adolescent psychiatrist, by the time the parents get to meet with the child needs to be on medication. The parents come in frazzled, totally frazzled, because the child has just progressed to such an extent that we need to intervene with medication. Adverse effects, again, very common side effects of utilizing the psychostimulant medications. Appetite suppression, we see that. And so it's important to explain to parents, it's okay when your child comes home at 3 or 4 o'clock, the medication is wearing off, your child's hungry, let your child eat. Feed your child when your child is hungry. So too, if they need another dose in the evening to help with homework and study, especially adolescents, give that second dose with dinner, not before dinner. We have to watch for disturbance of sleep. We have to watch, again, for cardiac issues. That's where family history is critical. Headaches, tics. I had a youngster recently, and I explained to the youngster, we're going to initiate this medication for you, a psychostimulant, and if you find that you're having tics, we want you to let us know. The child looked at me in all sincerity and said, Dr. Goldman, do I have to worry about fleas too? So it's important to explain to individuals what our medical verbiage means. This more subdued, yeah, too much is not good. Sometimes youngsters will experience a phenomenon of becoming zombified. We don't want to do that. Crying, sensitivity. What happens is this. There's a phenomenon called rebounding. When the medication comes off, some of these youngsters will now drop below the baseline where they were before we started the medication for that day. They may become more mood labile, tearful, irritable, more hyperactive. That means they need another dose of the medication, carefully scheduled in. Stimulant treatment, does it increase the likelihood of later substance abuse? It does not. In fact, the studies even show that. If we don't intervene to treat, these are the youngsters who are at greater risk of substance abuse because they're self-medicating. So we want to intervene to treat. I'm going to move through faster now because I know tempus fugit, time flies, and so I want to get this done and maybe do a visual demonstration before we leave that brings it all back together. Lisdexamfetamine, what is this? This is a form of dexamphetamine, the Adderall, as it were, that has a lysine molecule added to it. This helps guard against abuse and diversion on the street. Lisdexamfetamine, in order to be activated, has to get into the gut, have lysine cleaved, the amino acid cleaved from it, and then it activates it. So the individual can't open it, pour it out, snort it, and quote-unquote get a high. This has low street diversion potential. Lisdexamfetamine, you all may know it by the branded name of venlafaxine, and it comes in multiple doses, as you'll see, at 20, 30, 40, 50, 60, 70 milligram. 70 milligram is the max. Typically what we will do is use an immediate release Adderall, which is the amphetamine, dexamphetamine mixed salts. We'll test it for several days to see what dose works and how often it has to be dosed, and then we extrapolate from that as to which dose of the lisdexamfetamine that the youngster, adolescent, or adult needs. One of the advantages is if we have to, we can open the capsule, pour it into a liquid, stir it up, and the individual then can consume the liquid to get the medication. Methylphenidate patches, these are called Daytrana. This meters out transdermally the methylphenidate. Okay, this is for youngsters who tell you they have difficulty swallowing. They're great at putting away a Big Mac. When it comes to a pill, they have difficulty. What you have to watch for is underlying dermatologic disturbance. Any patches. 1 in 5 individuals who utilize a patch, whether it's replacing hormone replacement therapy or an antidepressant or some other treatment approach, we always have to watch for dermatologic disturbance. I've been given the 5-minute rule, so I'm hustling through for us. Each of these FDA-approved drugs is a non-stimulant treatment for ADHD except, so we're asking you, which one of these is a stimulant? All right, 71% of us said lisdexamfetamine dimesylate. You're right, that is the psychostimulant we were just talking about. That's Vyvanse. The other 3, I will give you those right now, we use. These are non-stimulant medications for treating ADHD. Clonidine, you all know that as catapress. That is an alpha-2 agonist that we use for treating ADHD, and it also helps with aggressive, angry acting out. We can give it at bedtime. Clonidine helps facilitate sleep as well. It comes at 0.1 milligram. Maximum dosing is 0.4 milligrams. You may find you have to cut it in half in the beginning. It is very sedating. It is effective. We also use it as a second-line treatment approach for tic disorders. Atomoxetine. Atomoxetine is Strattera. Strattera is the non-stimulant medication that we use. Strattera is very effective in treating ADHD as a non-stimulant medication. We don't have to worry about tics with it, as well as the clonidine. And when utilized, it is typically 1.8 milligrams per kilogram. It is now dosed up as high as 100 milligrams a day. It being a non-stimulant, you can get samples of it and even give starter kits to patients from your office. Guanfacine, which many of you will know as 10X, an alpha-2 agonist, is also available now as a non-stimulant treatment approach, FDA approved in children, adolescents, and adults as Intuniv, I-N-T-U-N-I-V. You get samples of that. You can also give that with a starter kit to your patients in the office. All of these are effective, and all of these are very reasonable options in treating your patients. Non-stimulant treatments, again, as we just noted, atomoxetine, which is Strattera, clonidine, and the guanfacine, which is Intuniv. Where do we look to using the atomoxetine or guanfacine first? We go to these areas. If someone's had a history of substance abuse, we're going to go to one of the non-stimulant approaches. If they have anxiety, we want to go to a non-stimulant approach. Again, this is the information on atomoxetine and guanfacine. I believe you all have these slides, yes, so you can check that. I'm just racing through. These give you the studies. I know I have 2 minutes left, and as our last speaker, I find that I have more slides than time. I apologize. When it comes to adverse effects, please check, because we have to monitor patients for any kind of impact on the liver when we utilize these medications. With the guanfacine XR, again, we may want to monitor clonidine and guanfacine. We may want to check blood pressures. Non-pharmacologic approaches, omega-3s are being used. Pycnogenol is one of the non-pharmacologic approaches as well. Exercise is critical. Service pets are a good thing as well for these patients. Working with the child, parent-child interactions. Who's at risk? 60% childhood patients persist on into adulthood. Points, again, everything we talked about. Medication, which one do you initiate? Look to family history as well. Were either parents on medication? Was it successful? Older siblings, have they been on medication? Were they successful? We look to that as well. Is there a family history of substance abuse? Again, be careful. You may prescribe a psychostimulant for a child. His parents may divert it to the street for extra income, or they may use it themselves. Please keep a healthy index of suspicion for that. This gives you information on accessing places on the web to help post-test and evaluation. If I may, we'll go through this now. What is the most common effect of stimulant agents in children with ADHD? Well, let's see what you all think now. I'm looking at this. Yes, 87% improved attention. Again, some voted for decreasing hyperactivity. The psychostimulants do both, as do the non-stimulants, so we ultimately get a 2-for-1. Okay, we went through. Which of the following is considered a behavior screening tool useful in screening for ADHD? You'll remember me talking about the tool that teachers use, that parents use, that we find most effective, has the greatest specificity and reliability, and we'll vote on that now. Yes, absolutely. The Connors, we did well. And now the evaluation. This is where you all tell me how I did. Please be kind.
Where's your robe? Yeah, let's see the robe.
Ah, okay, thank you.
Performance of the speaker.
And as you all vote, hopefully now, we have a better understanding of the ropes. You see, as we have the child with ADHD who has too short an attention span, we'll wait because you're going to vote on this, then we'll do the ropes. Learning objectives.
Learning objectives then.
How did we do? Was I fair and balanced?
A balanced view.
Yeah, sound like Fox News?
Were relationships between grantor and speaker announced prior to the presentation?
Yes, they were. An unrestricted grant, educational grant to OMEW, who has brought me in to present to you all today.
How useful will this session be in your practice?
Oh, I hope it helps.
As a result of this program, do you intend to change your patient care?
I'm sure you all have already been giving your patients the best care possible and with a good osteopathic approach. And now, the 3 lengths of rope. Now that we've seen all this and heard all of this, we know that when we place the 3 ropes into the hand, and And we take the ends of the ropes and we even them up. So now the ropes start and stop at the same place. Now if I were to ask you, are these ropes equal in length? You would say to me, no, Dave, they're not. They start and stop at the same place, yet their middles are different. So we want to be aware of our patients' middles when we're prescribing medications, keeping in mind that the psychostimulants may suppress appetite and cause our patients to lose weight, keeping in mind that for those patients we may need to switch to a non-psychostimulant so that our patient is able to eat again and put weight back on. Hopefully, through the magic of medicine, the benefit of science, and this presentation today, now, we notice that just as these 3 lengths of rope are equal, so too the balance in the child's life for whom we treat the ADHD is now found in equal measures so that home, school, and recreation are all equally successful for the child. Thank you very much for allowing me to present today. Please have a great rest of the conference. And it's good to see familiar faces. Thank you.